like to thank the program committee of the association for providing us with the opportunity to present our study of the early and late results following closure of ventricular septal defects in patients with elevated pulmonary vascular resistance and pulmonary hypertension utilizing the flap valve double patch technique. We have no disclosures to make. In upper income countries, large VSDs are closed in infancy before the development of pulmonary hypertension and elevated pulmonary vascular resistance. In low and middle income countries, the delay in diagnosis and treatment results in children presenting at an older age for VSD closure, having already established pulmonary hypertension and elevated resistance. Mortality risk in low and middle income countries is high for these patients, as these countries are without expensive medications for pulmonary hypertension treatment or ECMO rescue. We developed a unidirectional flow VSD closure patch to decrease the mortality risk. This is a single institutional retrospective study between May of 1996 and April of 2016. All patients presenting for VSD closure with PAH underwent cardiac catheterization with 100% oxygen provocation following baseline studies. Beginning in April of 2005, all patients presenting with VSD and PAH were started on sildenafil at 3 milligrams per kilogram per day for 2 to 3 months prior to cardiac catheterization. All patients who did not drop their PVR to normal with provocation received the unidirectional VSD closure patch. All patients received a pulmonary artery pressure line before leaving the operating room. An echocardiographic assessment of systolic PA pressure was obtained daily on discharge and at all follow-up visits. Analysis of the early and long-term results compared the sildenafil to the non-sildenafil groups. A total of 40 patients underwent double patch closure and are the subject of this study. Now here you can see the patient demographics and baseline hemodynamics, and as you can see, there's basically no difference between the demographics of the patients. Baseline hemodynamics, though, you do see differences in the systolic pulmonary artery pressure, the PA to systemic pressure ratio, the QPQS, the percentage of patients with a QPQS of less than 1.5, the absolute oxygen saturation, and the percentage of patients with oxygen saturation of less than 90%. All of these were much higher in the non-sildenafil group. Now, with oxygen provocation, only one thing changed between the two groups, and that was the QPQS. It rose to 3.16 in the sildenafil group and 1.70 in the non-sildenafil group. ICU and discharge data is seen here. The only thing that was really significantly different was mechanical ventilation time, which was significantly less in the sildenafil group. Inotropic score approached significance lower in the sildenafil group, but did not achieve significance. Hospital discharge mortality was 2.5%. Now, we looked at the pulmonary to systemic pressure ratios over time as a function of the median, and here you can see that there was a decrease, as you would expect, in pressure as the patients went through the system and had their VSD closed. Upon discharge, the mean pulmonary to systemic pressure ratios increased slightly, and there was a slight decrease at final follow-up. There was a significant difference between the lowest value, which was in the ICU, and the follow-up and discharge PA pressures. The degree of pulmonary hypertension at last follow-up, 21% with no, 40% with mild, 21% with moderate, and 18% with severe pulmonary hypertension. And as you can see from the Kaplan-Meier curve here, freedom from severe PAH was over 80% for both groups at 15 years and was actually 79.5% at 21 years for the non-sildenafil group. Freedom from death after discharge is seen here, and as you can see, there was excellent survival following discharge. As I mentioned, there was only one late death, and so we had a 97.3% overall survival at 15 years. Limitations of the study: it was retrospective, it was a single institution, it was a small sample size, and there was less time for follow-up in the sildenafil group. However, we believe the inferences are sildenafil pretreatment improves baseline catheterization hemodynamics and post-provocation QPQS compared to no pretreatment, thereby improving preoperative hemodynamics. Patients with sildenafil are extubated earlier postoperatively, facilitating postoperative management. Long-term survival is excellent in this cohort. Late severe pulmonary hypertension is less than 20%, and double patch operations in patients with severe PAH and elevated pulmonary vascular resistance can be carried out with low early and late mortality. Thank you very much for your attention.